Welcome back to the deep dive. Today we are shifting gears completely. We are entering exam mode.
Full exam mode.
Absolutely. If you're listening to this, there's a very good chance you're staring down the barrel of the Gujarat University MD anesthesiology exams.
Or the DNB finals. This topic is a classic everywhere.
Exactly. Or maybe you just want to finally truly understand the liver. We have pulled a massive stack of sources for this one. We're talking Harrison's, Miller's anesthesia, Stolting, Robbins pathology, you name it.
The whole library.
And our mission today is very, very specific. We are going to synthesize all of that into hopefully the perfect answer for a high-stakes, 20-mark long question.
Causes of hepatomegaly, alcoholism, and liver insult due to anesthesia.
That's the one.
It is a classic question. And honestly, it's a classic for a good reason.
Why is that?
Because it tests everything. I mean, it tests your knowledge of basic pathology, your grasp of pharmacology, and most importantly, your ability to manage a really complex, multi-system patient in the OT.
You can't just bluff your way through it.
Absolutely not. This is one of those questions where you really have to know your stuff inside and out.
And that's exactly why we have the senior faculty here with us today, our expert guide, to help us navigate this. Because let's be honest, you can't just walk into a theory exam or a Viva and start, listing random liver facts.
No, you need a strategy. You need a structure.
A structure.
Precisely. You need a narrative. If this comes up as a long question, the examiners at Gujarat University are looking for a cohesive structure. They want to see that you understand the why and the how, not just the what.
So we're building the answer from the ground up.
Exactly as you would write it on the paper, or how you would present it in a Viva, step by step.
I love that. Okay, so we have a clear roadmap. We're going to start with Part A, the introduction and exam framing.
Laying the groundwork.
Then Part B, hepatomegaly, the mechanisms and that all-important classification.
Very important.
Part C is the big one. Alcoholism, its whole spectrum, and all the systemic effects. Part D, the anesthetic management, the nuts and bolts. Part E, liver insult mechanisms. Part F, prevention. And finally, Part G, the Viva traps, and how to actually present your diagrams.
That is the plan. We're aiming for the gold standard answer here.
Yeah.
The one that gets you top marks.
Let's do it. Let's dive in. Part A, introduction. You turn over the exam paper, you see the question. Discuss hepatomegaly, alcoholism, and anesthetic liver insult. How do we start? Do we just write, hepatomegaly is a big liver and move on?
You could, but you would be missing a massive opportunity right at the start.
To grab their attention.
To grab the examiner's attention and show you understand the relevance. Yes, of course, you define hepatomegaly. You'd say, as per Harrison's, it's the enlargement of the liver beyond its normal anatomical span, so typically greater than 12 centimeters in the midclavicular line. Simple. Then you immediately pivot. You have to explain why an anesthetist cares.
Right. Because to us, the liver isn't just a big organ sitting in the right hypochondrium. It's the factory.
It's the metabolic powerhouse.
Yeah.
Exactly. You need to state that clearly in your intro. Something like, the liver is central to anesthetic practice because it dictates drug metabolism, coagulation status, and glucose homeostasis.
I like that. So you frame the whole answer right there.
You frame the answer around the triad. Hepatomegaly is the clinical sign. Alcoholism is the most common pathology we see causing it. And anesthetic insult is the iatrogenic risk we're always trying to mitigate.
That sets the stage perfectly. It tells the examiner, I know what this organ does, and I know why we're talking about it. You've basically given them your table of contents in the first paragraph.
Correct. And you should also mention that while this often appears as a 20-mark theory question, specific components, like, say, Halothane hepatitis or alcohol withdrawal, can pop up as short notes or Viva questions. Shows you know the exam pattern.
Okay, that's a brilliant start. Let's move to Part B, hepatomegaly. We've defined it. Now, the mechanisms. You've listed this as very high yield. Why?
Because students so often skip the pathophysiology. They learn the list of causes, but they don't know why the liver actually gets big.
They learn the what, not the why.
Exactly. But if you can explain the mechanism, you show a much deeper levels of understanding. According to Robbins pathology, there are really only 4 fundamental ways the liver can physically enlarge.
Okay, let's unpack those. What's number 1?
Number 1 is inflammation. This is the most intuitive one.
Like in hepatitis.
Yes, think about viral hepatitis or alcoholic hepatitis. The hepatocytes themselves, the liver cells, they swell up. Pathologists have a great term for it. Ballooning degeneration.
Ballooning.
And on top of that, the liver tissue gets infiltrated by inflammatory cells, lymphocytes, neutrophils, and so on. So the organ literally swells up, just like an inflamed ankle would.
That's a great visual. An inflamed ankle. Okay, so that's mechanism 1, inflammation. What's next?
Mechanism 2 is congestion. And this is huge for us in cardiac anesthesia. We call it the nutmeg liver.
I remember that term from med school, nutmeg liver. I never quite understood why.
It's a classic. So if you have right-sided heart failure or severe tricuspid regurgitation, the blood can't get out of the liver properly via the hepatic veins. It just backs up.
The traffic jam.
A big traffic jam.
Yeah.
The sinusoids and the central veins become distended with blood. It's called passive congestion. And the liver becomes large, tender, and sometimes you can even feel it pulsating.
And the nutmeg part is because of how it looks on a cut section.
Exactly. The dark red spots are the congested blood around the central veins. That's zone 3 of the acinus. And the paler, tan-colored areas are the fatty or normal tissue in zone 1. It looks just like a grated nutmeg.
Got it. Okay, so we have inflammation and congestion. What's number 3?
Mechanism 3 is fatty infiltration. The technical term is steatosis.
Which brings us right back to our main topic of alcoholism.
Right. Or non-alcoholic fatty liver disease, NAFLD, which is an absolute epidemic now. What's happening is the hepatocytes are just getting stuffed with triglyceride droplets. It starts as microvesicular, tiny little drops, and then becomes macrovesicular, one big blob of fat that pushes the cell nucleus off to the side.
And the liver itself just gets bigger and yellower?
Exactly. Large, yellow, and greasy.
Okay, so inflammation, congestion, fatty infiltration. Is there a fourth?
Yes. The fourth one is infiltration by abnormal substances or cells. This is a bit of a catch-all.
So this is where cancer comes in.
Yes. This could be malignant cells, a primary hepatocellular carcinoma, or more commonly metastases, or it could be abnormal proteins like an amyloidosis. Or in the glycogen storage diseases, the liver gets packed with glycogen.
So purely from an anesthetic perspective, just for a moment, why does the physical size matter, aside from telling us there's pathology inside?
It's a very real mechanical problem. A massive liver pushes up on the diaphragm. It physically reduces your functional residual capacity, your FRC. That predisposes the patient to basal atelectasis, lung collapse during and after surgery. It can also make the surgical exposure much more difficult. So it's not just a biochemical problem, it's an anatomical one.
That is a key takeaway. Big liver equals reduced FRC. Okay, that's brilliant. Moving on to section 3. Causes of hepatomegaly. The exam core. And you've written in big letters, must be classified.
Never, ever write a laundry list.
Yeah.
I can't stress this enough. Examiners hate random lists.
They just look messy.
They look messy and they show you haven't organized your thoughts. If you just write down alcohol, malaria, cancer, you might scrape a pass, but you won't get good marks. You must classify. If you classify, you pass. We generally use a standard medical classification based on Harrison's.
Okay, give me the buckets. What's the framework for the classification?
Bucket 1, infective. This is very relevant here in India. You have to mention viral hepatitis A, B, C, D, and E. Then liver abscess, both amoebic and pyogenic. Hydatid cyst is another classic. And please do not forget malaria.
Malaria. I always associate that more with the spleen.
It causes massive splenomegaly for sure, but it
Right.
frequently causes hepatomegaly too. It's a key differential.
Got it. Infective. Bucket 2.
Metabolic. This is where our main topic, alcohol, sits. So alcoholic fatty liver. But you must also mention NAFLD, which is now more common than alcoholic liver disease in many places.
And the rarer ones.
The ones you mentioned to show you've read properly. Hemochromatosis, which is iron overload. Wilson's disease, which is copper. And the glycogen storage diseases.
Okay, so infective, metabolic. What about the heart connection we just talked about?
That's bucket 3, vascular or congestive. So you put congestive cardiac failure, CCF, in there,
Right.
tricuspid regurgitation. And a specific exam favorite is Budd-Chiari syndrome.
That's the hepatic vein obstruction, right?
Obstruction of the hepatic veins. It causes massive, painful hepatomegaly and ascites. It's a classic triad.
And finally,
neoplastic. This is cancer. You divide it into primary, which is hepatocellular carcinoma or HCC, often following cirrhosis, and then secondary, which is metastases. The liver is a very common site for mets from the colon, stomach, or breast.
so just to recap that classification, infective, metabolic, vascular, and neoplastic. And I guess we could add a fifth bucket for toxic, which would loop us back to alcohol and other drugs.
Exactly. If you write that down in a table in the exam, it looks professional. It shows you think like a consultant.
Perfect. Now, before we dive into alcohol specifically, let's talk about the clinical features. We're in the pre-op clinic. We see a patient who, on examination, has hepatomegaly. What else are we looking for? What are the systemic effects that really matter to us as anesthetists?
You're looking for two big things,
Mm-hmm.
the stigmata of liver cell failure and the signs of choroidal hypertension.
Let's start with liver cell failure. What are the signs?
Start with the hands. Always look at the hands. You might see palmar erythema red palms.
Dupuytren's contracture.
Yes. And look at the nails. You can see leukonychia, which are white nails, from low albumin. Then look at the skin. You're looking for spider angiomata.
The little red spiders on the chest? That's a classic Viva question, isn't it? Why do we get those?
It is. And the answer is altered estrogen metabolism. The failing liver isn't breaking down estrogen effectively, so you get these little vascular dilations in the distribution of the superior vena cava.
And for us, the anesthetist, what does that sign really mean?
If you see spider nevi, you have to assume the liver's synthetic function is compromised. It's a huge red flag for potential bleeding. It means coagulopathy until proven otherwise.
Okay, so those are signs of cell failure. What about portal hypertension?
That's the really dangerous stuff. You look for caput medusae distended veins radiating from the umbilicus.
And the big one.
Esophageal varices. You might not see them, but you have to suspect them. This is a massive bleeding risk if you're thinking about putting in a nasogastric tube or a T-probe intraoperatively.
You could cause life-threatening hemorrhage.
Easily. Then you have splenomegaly. The big spleen sequesters platelets, leading to thrombocytopenia. And of course, ascites.
Ascites is a nightmare for breathing, isn't it?
It splints the diaphragm, it dramatically reduces your FRC even further than the big liver alone. And crucially, it increases the risk of reflux and aspiration.
So, if you see ascites,
you are treating that patient as a full stomach risk, period, regardless of their fasting guidelines. That is a non-negotiable rule.
ascites equals full stomach. Got it. Okay, let's pivot now to part C, alcoholism and liver disease. This is the second major pillar of our long question.
And this is extremely high yield. The key thing you have to communicate in your answer is that alcoholism is a multi-system disease. It is not just about the liver.
Okay, so how do we define it for the exam?
According to standard textbooks like K.D. Tripathi or Miller, it's chronic consumption leading to physical or psychological dependence and, importantly, organ damage. But for the exam, what the examiners really want to see is that you can describe the spectrum of alcoholic liver disease. It's a progression.
A continuum. Walk us through the stages. Is it inevitable that every alcoholic gets cirrhosis?
No, and that's a common misconception and a bit of a trap. It's continuum, and not everyone goes all the way. Stage 1 is fatty liver or steatosis.
And that's almost universal in heavy drinkers.
It happens in 90 to 100% of them. It's simply the accumulation of fat droplets in the liver cells. But here's the key fact for this stage. It is reversible.
Completely reversible.
Yes. If they stop drinking, the fat mobilizes and the liver can return to normal. This is a critical point to make.
Okay, that's stage 1, reversible. What's stage 2?
Stage 2 is alcoholic hepatitis. Now we've moved from just fat to active inflammation. We have hepatocyte necrosis, ballooning degeneration, and here's your pathology keyword for the day. Mallory-Denk bodies.
Mallory-Denk bodies, you have to mention those.
You absolutely have to. They are clumps of damaged intermediate filaments, basically cytokeratin, that form inside the liver cells. If you mention Mallory-Denk bodies in your answer or Viva, you are signaling that you've read Robbins' pathology.
And this stage is much more serious.
Much more. This stage is dangerous. Patients can be febrile, have a tender liver, a high white cell count, and be very, very sick. The mortality rate in an acute episode of alcoholic hepatitis is high.
Okay. And the final stage?
Stage 3 is cirrhosis. This is the end stage. You have extensive fibrosis, regenerating nodules, and a completely distorted architecture. This is irreversible.
And what percentage of alcoholics get to this stage?
It's actually only about 10 to 20%. But this is the stage that terrifies anesthetists. This is where you have the full-blown picture of portal hypertension, coagulopathy, and encephalopathy.
So the progression is fatty liver hepatitis cirrhosis.
Got it.
Now, you said alcoholism is a multi-system disease. I feel like this is where the anesthetist really has to put their physician hat on and be a detective.
Yeah.
What else is broken in a chronic alcoholic?
Everything. Let's go through it system by system. This is an absolutely essential part of your answer.
Yeah.
Let's start with the cardiovascular system.
Okay.
Alcohol is directly toxic to heart muscle. You get alcoholic cardiomyopathy,
Which is a dilated cardiomyopathy.
a dilated flabby heart with a reduced ejection fraction. They are in heart failure. You also get arrhythmias, specifically something called holiday heart syndrome.
That's atrial fibrillation after a binge.
Exactly. And
Yeah.
you often have underlying hypertension as well, so you can't assume their pump function is normal.
Never. So you're thinking of getting an echocardiogram pre-op.
You must get an echo. Absolutely. Okay, next, the CNS, the brain.
The brain is basically marinated in alcohol.
It is. The first thing to consider is tolerance to sedatives. We'll come back to this in detail later. But structurally, you get cerebral atrophy. And you have nutritional deficits, which lead to Wernicke-Korsakoff syndrome.
Thiamine deficiency.
Yes, B1 deficiency. Wernicke's is the acute reversible part. Confusion, ataxia, and ophthalmoplegia. Korsakoff's is the chronic irreversible memory loss.
And there's a vital clinical pearl here, isn't there, about giving glucose?
A critical safety point. If you treat hypoglycemia in an alcoholic with a glucose drip before you've given thiamine, you can precipitate Wernicke's and cause permanent brain damage. The brain's metabolic pathways for glucose require thiamine as a cofactor. If you provide the fuel without the spark plug, the engine dies.
Always give thiamine first. 100 milligrams the fee.
Thiamine before glucose.
Vital.
Okay, next system. Hematological, the blood.
The clay on there.
Multiple things. You have direct bone marrow suppression from the alcohol. You have thrombocytopenia, low platelets, either from that merotoxicity or because the big spleen and portal hypertension is sequestering them.
And anemia.
Often a macrocytic anemia, big red cells due to folate deficiency. And then, of course, the big one, coagulopathy. The liver isn't making clotting factors 2, 7, 9, X, and X.
Okay, and the GI system?
Gastrointestinal. Gastritis is almost universal. Alcoholics have inflamed stomachs. They have delayed gastric emptying. They may have esophageal varices. So what does that all scream to an anesthetist?
Aspiration risk. Full stomach. RSI.
Every single time. It really is a wrecking ball throughout the entire body.
Yeah.
Now let's talk about one of the scariest perioperative complications, alcohol withdrawal.
This is an exam core topic. You have to know this.
You must know the timeline.
Okay, let's map it out. A patient comes in for surgery, so they're forced to stop drinking. The clock starts ticking from their last drink.
Right. At 68 hours, the minor symptoms start. You get tremors, the shakes. The patient becomes anxious, tachycardic. And here's the clinical trap. Post-op, this tachycardia is often mistaken for pain or hypovolemia.
So you give them more morphine, and it doesn't work.
It doesn't work, and the heart rate is still 120. You have to think, could this be withdrawal?
Okay, that's 6 to 8 hours. What's next?
24 to 48 hours. This is the danger zone for seizures. They're sometimes called rum fits. These are generalized tonic-clonic seizures. They can happen even if the patient seems relatively lucid otherwise.
And then comes the big storm.
48 to 96 hours. This is when you can get delirium tremens or DTs. This is a full-blown medical emergency. The mortality rate is high if it's not treated aggressively.
What does it look like?
It's a hyperadrenergic state. You get sky-high blood pressure, fever, a very fast heart rate. The patient is agitated, globally confused, and has vivid hallucinations, often tactile ones like formication, the sensation of bugs crawling on their skin.
It sounds absolutely terrifying. How do we manage it? Or better yet, how do we prevent it?
Prevention is everything. The key is to identify the at-risk patient preoperatively. You can use screening tools like the CAGE questionnaire or the IUD-IT score.
And if they screen positive?
Then you need to think about prophylaxis. The gold standard for treatment and prevention is benzodiazepines.
Diazepam or lorazepam?
Exactly. They are the gold standard because they act on the same GABA receptors that alcohol does. You're essentially substituting one GABA agonist for another, safer one, and then weaning it.
Okay, so we've covered the pathology in detail. Now let's get really practical.
Yeah.
Part D, anesthetic implications. We have a patient with diagnosed alcoholic liver disease on our operating list for the day. How do we assess them preoperatively?
You need to risk stratify them. This is not just a vague clinical impression. You have to use scoring systems, and you must mention 2 of them in your exam answer.
Number 1 is?
First, the classic Child-Pugh score.
I use the mnemonic pour another beer at 11.
Juggles. That's the one everyone uses. It works. So that's P for PT or INR, A for ascites, B for bilirubin, another R for albumin, and E for encephalopathy.
And you get a score, and it puts them in a class.
Class A, B, or C. The key point to make is that Child-Pugh Class C carries a very high perioperative mortality, sometimes approaching 50% for major abdominal surgery. So it really changes your risk-benefit discussion with the patient and surgeon.
And the second score we need to mention.
The MELD score. That stands for Model for End-Stage Liver Disease. This is what's used for liver transplant priority listing.
What does it use?
It's a formula that uses bilirubin, INR, and crucially, creatinine. Note that creatinine is in the MLE score, but not in Child-Pugh. This is important because renal function is a huge predictor of survival in liver patients. You have to mention the risk of hepatorenal syndrome.
Okay, so we've scored them. Now we're in the theater. Intraoperative considerations. You mentioned earlier the tolerance paradox. This seems like a classic Viva question.
It is. The examiner will lean forward and ask, so this alcoholic patient, do they need more anesthesia or less? And the correct answer is, it depends.
It depends on whether they're acutely intoxicated or not.
Precisely. Let's take scenario A. The chronic alcoholic who is sober on the day of surgery. Their liver has been working overtime for years to metabolize alcohol. This causes enzyme induction, specifically of the CYP2E1 system.
So their engine is revved up, they chew through drugs faster.
Much faster. They will be tolerant. They will require higher doses of Propofol to go to sleep, higher doses of opioids for pain, and a higher amyloidal agent to stay anesthetized.
Okay. Now, scenario B. The acutely intoxicated patient. They come into the emergency department for trauma, and they smell like a brewery.
It's a completely different ballgame. In this patient, the alcohol is currently occupying those same enzymes. It's acting as a competitive inhibitor. Plus, the alcohol itself is a CNS depressant.
So the effects are additive.
They are additive. These patients need much lower doses. They are incredibly sensitive. A small dose of Propofol that would barely touch a normal patient might cause apnea in them.
That is such a critical distinction to make. Chronic sober means high dose. Acute drunk means low dose. What about our induction technique?
It has to be a rapid sequence induction. RSI. We've already established they have gastritis, delayed gastric emptying, and maybe ascites. You do not take chances with that airway. You protect it.
Okay. And muscle relaxants. Which ones do we choose?
This is another key decision point. If their liver function is significantly impaired, you want to avoid drugs that depend heavily on the liver for metabolism or biliary excretion.
So vecuronium and rocuronium might be a problem.
They might have a prolonged duration of action. The liver is supposed to clear them, and if it can't, the drug just hangs around for much longer. The elimination half-life stretches way out.
So what's the go-to relaxant?
Atracurium or cisatracurium.
Why?
Because they undergo Hoffman elimination. They break down spontaneously in the plasma, dependent on pH and temperature. It's a chemical process, completely independent of the liver or the kidneys. They're the safest choice in this situation.
That is a textbook answer right there. Atracurium or cisatracurium for liver patients. What about succinylcholine for the RSI?
You have to be a little bit careful. Succinylcholine is metabolized by plasmacholinesterase, which is also called pseudocholinesterase. And where is that enzyme made?
In the liver.
Exactly.
Right.
So in severe liver failure, you'll have low levels of plasmacholinesterase. That means the succinylcholine might last much longer. Instead of 5 minutes, it might last 20 or 30 minutes.
Is that a deal breaker?
Usually not for an RSI, because you've already secured the airway with the tube, so you just support their ventilation until it wears off. But you absolutely need to be aware of it and anticipate it.
Right. What about post-op management? Pain control seems like a minefield.
It's very tricky. First, you generally want to avoid NSAIDs.
Why is that? The bleeding risk.
That's part of it, yes, due to platelet dysfunction. But the bigger issue is the kidneys. In these patients, renal blood flow is often critically dependent on prostaglandins. If you give an NSAID, you block prostaglandin synthesis, and you can precipitate hepatadrenal syndrome, which is often fatal.
So NSAIDs are out. What about paracetamol?
Acetaminophen or paracetamol is controversial. In a stable cirrhotic, low doses, maybe 2 grams a day max, are usually considered safe. But in an active, malnourished alcoholic, they had depleted stores of glutathione.
And glutathione is what you need to detoxify the paracetamol metabolite.
Exactly. It detoxifies the toxic metabolite, NAPQI. If you run out of glutathione, that metabolite builds up and causes liver necrosis. So you have to use it with extreme caution, if at all.
So we're kind of pushed towards using opioids?
We are, but carefully. Fentanyl is usually okay, but you have to watch for prolonged respiratory depression if their liver clearance is slow. Remifentanil is fantastic intraoperatively because it's metabolized by tissue esterases, so it doesn't care about the liver at all. But post-op, you are often stuck with giving very small, titrated doses of fentanyl or relying on regional techniques.
But regional anesthesia is limited by their coagulation status, right?
Exactly. An epidural would be fantastic for their physiology, great pain relief, no systemic opioids. But if the INR is 2.0 and the platelets are 40,000, you absolutely cannot put a needle in their back. You risk causing an epidural hematoma, which is a neurological catastrophe.
It really is a tightrope walk. Okay, let's move to Part E, liver insult due to anesthesia. This is the part of the question that asks, did the anesthetist break the liver?
It's a very sensitive topic. And I think historically we focused very heavily on direct drug toxicity. But in modern practice, the biggest enemy of the liver in the perioperative period is ischemia.
So let's break down the mechanisms of injury.
There are two main buckets you should describe. Bucket one is ischemic hepatitis, which is often called shock liver. This is purely caused by hypoperfusion. Think hypotension, massive hemorrhage, sepsis.
Not enough blood flow, not enough oxygen.
Exactly. And bucket two is drug-induced hepatotoxicity. This can be a direct toxic effect or, more classically, an immune-mediated effect.
Okay, let's talk physiology first, because you've flagged this as exam gold. How does anesthesia actually affect hepatic blood flow?
To answer this, you have to start by describing the dual blood supply. This is a physiological quirk that's unique to the liver.
Right, it gets blood from two sources.
Yes, it gets about 75% of its blood flow from the portal vein, which is deoxygenated blood coming from the gut. And it gets the other 25% of its flow from the hepatic artery, which is oxygenated blood straight from the aorta.
But the oxygen supply is split differently, isn't it?
It is about 50-50. The portal vein delivers half the oxygen, and the hepatic artery delivers the other half. And this sets up a really elegant reflex.
The hepatic arterial buffer response, the HABR.
This is the crucial concept you have to explain in the exam. The portal vein is just a passive pipe. It can't regulate its own flow. But the hepatic artery can. If portal vein flow drops for any reason, say due to hypotension or a surgeon pulling on the gut adenosine accumulates in the liver, this adenosine causes powerful vasodilation of the hepatic artery.
So the artery widens to compensate for the drop in flow from the vein.
It's a buffer. Flow drops in the vein, adenosine builds up, the artery dilates, and the total oxygen supply to the liver is maintained. It's a beautiful protective mechanism.
So where do anesthetics come in? Do they mess with this reflex?
They do. General anesthesia in general tends to drop cardiac output, which reduces portal flow. Now here's where the choice of agent matters. Halothane is the classic villain. It completely abolishes the HABR.
So it takes away the safety net.
It cuts the safety cord. With halothane, portal flow drops, and the artery does not dilate to compensate. The liver just becomes ischemic.
And the modern agent?
Isoflurane, sevoflurane, and desflurane generally preserve the HABR. They are vasodilators themselves, but they leave that crucial reflex intact. This is a major reason why they are so much safer for the liver than halothane was.
That's a very clear physiological reason to choose Sevo over halothane. What about ventilation? Does PEEP affect liver blood flow?
It does. PEEP, or positive expiratory pressure, increases the pressure inside the chest. This pushes down on the diaphragm and increases the back pressure in the inferior vena cava. This creates a resistance to blood flowing out of the liver.
So it causes congestion.
It causes hepatic congestion and reduces the pressure gradient driving portal blood flow. So in a borderline liver, cranking up the PEEP too high can actually tip them into ischemia.
Speaking of halothane, we have to talk about halothane hepatitis. It's very rare now, but it's still in every exam.
It is the classic model of immune-mediated hepatotoxicity. It's important to understand it's not a direct poison. It happens because halothane is metabolized. About 20% of it gets broken down by the CYP2E1 system.
And 20% is a huge amount for a volatile agent.
It is massive. Modern agents like isoflurane are less than 0.2%. This halothane metabolism produces a reactive metabolite called trifluoroacetyl chloride, or TFA.
And this TFA is the problem.
This TFA acts as what we call a hapten. It binds to proteins on the surface of liver cells and creates a neoantigen.
A new target for the immune system. The body thinks its own liver cells are foreign.
Exactly. In a susceptible person, the immune system launches a massive attack against these neoantigens, causing widespread liver necrosis. It's essentially an allergic-type reaction to your own liver cells.
And there are classic risk factors, right? The Fs.
The mnemonic is female, fat, and 40-some middle-aged women, and a history of multiple exposures to halothane. The first exposure sensitizes the patient, and the second one triggers the massive immune response. It typically presents with fever and jaundice about 3 to 14 days after the anesthetic.
Okay, so let's put it all together. You have a patient who turns yellow 3 days after surgery. You're called to review them. This is post-anesthetic hepatitis. What is the differential diagnosis?
The first rule is, do not immediately jump to the conclusion, I caused this with my drugs. You have to be systematic. First, think of surgical causes.
Like a bile duct injury.
Did the surgeon accidentally tie off the bile duct? Is there a retained gallstone? That's an obstructive jaundice. Second, think of ischemic causes. Look at the anesthetic chart. Did the patient have a period of profound hypotension or massive bleed? That causes shock liver, which gives you a massive spike in the enzymes, the AST and ALT. That usually resolves quickly if perfusion is restored.
Okay, surgical ischemic. What else?
Third, think of viral causes. Could they have transfusion-related hepatitis? It's much rarer now with modern screening, but it's still possible. Or did they have a pre-existing, undiagnosed viral hepatitis? Fourth, consider Gilbert syndrome. About 5% of the population has this. The stress of surgery and fasting can trigger a mild, unconjugated hyperbilirubinemia. And then finally, at the bottom of your list, you consider drug-induced causes. Was it halothane? Or was it an antibiotic they received or an anticonvulsant?
That's a fantastic, safe, and systematic checklist. Okay, we're moving into the home stretch. Part F, prevention and safe practice. How do we actively protect the liver during our anesthetic?
It really boils down to two main principles: maintenance of perfusion and avoidance of toxins.
Let's break that down.
Number one, maintain perfusion. This is paramount. Keep the mean arterial pressure, the MAP, near the patient's baseline. Avoid prolonged periods of hypotension. Use fluids. Use vasopressors if you need to. Maintain cardiac output.
Number two.
Oxygenation. Avoid hypoxia at all costs. The cells in zone 3 of the liver acinus, the central lobular cells, are already living on the edge of hypoxia. Any further drop in oxygen delivery will kill them first.
Number three, drug choice.
Use isoflurane or sevoflurane to preserve that hepatic arterial buffer response. For muscle relaxation, use etracurium or cisatracurium, which are independent of liver function.
And number four, avoid other toxins.
Be very careful with drugs like paracetamol or NSAIDs in susceptible patients. And finally, monitor appropriately. If you're expecting hemodynamic instability, use an arterial line for continuous blood pressure monitoring.
Simple, actionable rules. Perfect. Now, Part G, exam integration. We want our listeners to visualize their answer sheet. What tables should they actually draw? Visuals get marks.
They absolutely do, and they save you time. If you don't use tables, you probably won't finish the paper. Table 1 should be your classification of hepatomegaly, 4 columns. Infective, metabolic, vascular, neoplastic. Fill in the key examples for each.
Okay.
Table 2 should be the Child 2 score. Write out the 5 parameters: bilirubin, albumin, PT, ascites, encephalopathy, and the point system 1, 2, and 3. And Table 3 should be a comparison of halothane versus isoflurane versus sevoflurane. You should have rows for metabolism rate, effect on hepatic blood flow, effect on HABR, and hepatotoxicity risk.
What about diagrams?
You should definitely draw the liver acinus. Just a simple diamond shape is fine. Show zone 1, the periportal area, which is oxygen-rich, and show zone 3, the central lobular area around the central vein, which is oxygen-poor. Then you can label zone 3 as a primary site of both ischemic injury and P450 enzyme activity. It shows you understand the microanatomy.
Any other diagrams?
A simple flowchart of alcohol metabolism is also very effective. Show ethanol being converted to acetaldehyde by alcohol dehydrogenase and then to acetate by aldehyde dehydrogenase. You can show how this process consumes NAD+ and converts it to NADH, and how that high NADH-NAD+ ratio is what drives fatty liver.
Excellent. Finally, let's talk about the Viva traps. In a high-pressure oral exam, what are the common mistakes that make an examiner fail a student on this topic?
Trap number 1, forgetting hypoglycemia. Alcoholics have depleted glycogen stores, and alcohol itself inhibits gluconeogenesis. They can become profoundly hypoglycemic under the stress of surgery and anesthesia. If you don't mention monitoring their blood sugar, the examiner will think you're unsafe.
Okay, that's a big one. Trap 2.
Trap 2. Listing the causes of hepatomegaly without classifying them. We've talked about this. A random list just looks like you've memorized facts without understanding them. Immediate fail in some examiners' eyes.
Trap 3.
Trap 3. Ignoring the full stomach. If the examiner asks how you'd induce this patient and you start talking about a mask induction or a gentle IV induction, you failed. It's RSI. You have to say RSI.
And the last one?
Trap 4. Confusing acute versus chronic alcohol tolerance. Getting the dose requirements wrong. If you overdose the acutely drunk patient or underdose the chronic sober alcoholic, you're showing a fundamental lack of pharmacological understanding.
That is a masterclass in exam prep. Okay, let's try to summarize this entire dense deep dive into a 60-second elevator pitch for the exam, the final take-home points.
Here is your 20-mark summary.
Intro. Define hepatomegaly and immediately state its relevance to anesthesia, metabolism, clotting, and drug handling.
Hepatomegaly. Classify the causes neatly into infective, metabolic, vascular, and neoplastic. Explain the 4 mechanisms: inflammation, congestion, fatty infiltration, and malignant infiltration.
Got it.
Number 3, alcoholism. Detail it as a multi-system disease. Describe the liver progression from fatty liver to cirrhosis. And don't forget the CVS, CNS, and hematological effects. You must mention the withdrawal timeline.
Anesthetic plan. Pre-op, use the Child-Pugh score. Intra-op, it's RSI. Use atracurium and preserve the HABR with sevoflurane or isoflurane.
And the last points.
Number 5, liver insult. Clearly distinguish between the common problem, ischemia or shock liver, and the rare one, immune-mediated toxicity like halothane hepatitis. And number 6, prevention. It all comes down to maintaining perfusion and oxygenation.
Classify, justify, and you will pass. I love that.
That's the mantra for this question.
This has been an incredibly dense deep dive, but honestly, if you can articulate these points clearly, you aren't just going to pass the exam, you're going to be a much safer and more thoughtful anesthetist.
Absolutely. The liver is a very forgiving organ until it isn't. You have to respect the pathology.
A huge thank you to our senior faculty for breaking this down so clearly. To all the Gujarat University candidates and everyone else listening, good luck. Visualize those tables, remember the mechanisms, and as always,
Keep digging deep.
we'll see you next time on The Deep Dive.